Okay, guys, I've got D for you now. We're discussing more evidence of mental health needs, medication use in patients with cancer. Okay, so that's D for you. Here we go. More evidence of mental health needs, medication use in patients with cancer. Mental health burden among cancer survivors. Higher prescription rates. Cancer survivors are significantly more likely to be prescribed medications for depression and anxiety. 32% higher for antidepressants, nearly 40% higher for anti logistics, anti-anxiety meds, insurance disparities. Those on Medicare, Medicaid had notably higher rates of anxiety prescriptions. Okay. Give me 1 second, guys. Gotta change paper. One down. Okay, cancer type matters. Survivors of poor prognosis cancers were more likely to receive antidepressants. Implications for care. The study reinforces that depression and anxiety are especially prevalent in the cancer population. Authors stress that mental health care should be prioritized throughout cancer treatment due to its impact on survival and quality of life. Okay, then we've got equity concerns. Okay, the data suggests potential discrepancies in access to mental health medications among cancer survivors, highlighting a need for more equitable care strategies. Okay, this adds to the growing body of evidence that mental health support is not just complementary but essential in oncology care. If you're thinking about how to integrate this into your frameworks on outreach, I'd love to brainstorm culturally responsive or policy level adaptations with you. Here are 3 compelling recent studies that shed light on the evolving intersection of cancer and mental health care. Okay, number 1, mental health care need for cancer patients more than ever. Source: Psychiatry, January 2025. Up to 40% of cancer patients experience significant psychological distress, including anxiety, depression, and PTSD. Okay. The emotional toll begins at diagnosis and often persists along after treatment ends. Financial toxicity. The economic burden of treatment exacerbates mental strain. Some cancer centers are now embedding mental health professionals and implementing stress screening programs. Mental health trajectories in young adult cancer survivors. Source: University of Michigan, May 2025. Survivors diagnosed between age 15 and 39 show persistently elevated depression and anxiety across their lifespan. Depression follows a U-shaped curve, peaking in middle and older adulthood. Anxiety tends to stabilize over time, suggesting potential resilience. Highlights the need for lifelong psychological support tailored to this unique group. Depression and anxiety among people living beyond cancer. Source: BMC Cancer, 2019. Synthesizes multiple systematic reviews on cancer and common mental disorders. Finds higher prevalence of depression and anxiety compared to the general population. Notes a lack of high quality studies on long-term survivors, especially in low and middle income countries. Urges more research into prevention and the late effects of cancer treatment on mental health. If you'd like, I can help you co-design a culturally responsive framework that integrates these findings into caregiver toolkits or community-based programs. Want to dive into one of these studies more deeply? These recent studies are reshaping cancer care by elevating mental health from a peripheral concern to a core component of treatment strategy. Here's how they're shaping up. Influencing clinical practice, policy, and care models. Mental health as a survival factor. Studies show that depression and anxiety directly affect treatment adherence, recovery, and survival. This has led to calls for routine mental health screenings at diagnosis and throughout treatment, not just post treatment, to integrated psychological oncology. Institutions are embedding interdisciplinary teams, psychologists, social workers, and psychiatrics into oncology settings. This model improves outcomes by addressing emotional distress, treatment, fatigue, and social isolation in real time. Equity-driven interventions, data on discrepancies, e.g. higher antidepressants use among Medicare, Medicaid patients, is promoting policy-level responses to improve access to mental health care. There's growing emphasis on culturally responsive care, especially for underserved and marginalized populations. Patient-reported outcomes. Tools like PROMS are being used to track mental health symptoms longitudinally. These metrics are now influencing clinical decision making, such as adjusting treatment intensity or timing based on psychological readiness, global and lifespan adaptations. Studies highlight gaps in care for young adult, long-term survivors, and low-income countries. This is driving innovation in digital outreach, peer support networks, and community-based mental health programs. If you're thinking about adapting these insights into caregiver toolkits or participatory frameworks, we could co-design a model that blends clinical rigor with cultural humanity. Want to explore how these could be tailored for aging populations or end-of-life care contexts. Okay, culturally responsive care comes alive when providers move beyond textbooks and knowledge and truly adapt to the lived realities of diverse patients. Here are some compelling real-time or real-world examples that illustrate how this approach is practiced across settings. Spiritual integration of end-of-life care. In hospice settings, staff support patients by improving access to religious items like prayer beads, holy books, or spiritual statues. Coordinating with local faith leaders for bedside rituals or virtual services, respecting prayer schedules, e.g., early morning prayers for Muslims and dietary needs during religious observances like Ramadan. Okay. 2. Respecting cultural hygiene norms. Caregivers adapt grooming and hygiene routines to align with cultural expectations. In the South and South Asian cultures, the right hand is considered clean, so food is served accordingly, and nail trimming may follow specific hand order. According to avoiding nail polish for patients who view it as spiritually unclean due to water soluble concerns. Language and communication tailoring. Providers use bilingual staff to interpreters to ensure accurate communication. Culturally adaptive health education materials that reflect community values and literacy levels. Visual aids and storytelling methods for populations with oral traditions. Mental health framing for BILPOC. Mental health professionals. Validate cultural expressions of distress, e.g., somatic symbols like headaches, instead of verbalizing sadness. Access stigma and historical trauma by creating safe, affirming spaces. Use identity affirming language and frameworks that resonate with clients' lived experiences. Intersectional assessments in primary care. Give me 1 minute, guys. Okay. Clinics assess not just medical but history, but social identities, race, gender, class, immigration status, and how they intersect. Structural barriers like housing insecurity and discrimination. Community assets like family networks, uh, or traditional healing practices that can be integrated into care plans. These examples show how culturally responsive care isn't just about being aware, it's about adapting, co creating, and honoring the full humanity of each patient. If you're building toolkits or outreach programs, we could prototype models that embed these practices into aging, cognitive health, and end of life frameworks. Want to sketch one out together? Implementing culturally responsive care is transformative, but it's not without its hurdles. Providers often face a mix of systematic interpret interpersonal and emotional challenges that can complicate even the most well uh, inter intern motion efforts. Here's a breakdown of key barriers. Okay, structural and resource constraints, time pressures in clinical settings limit deep cultural engagements, lack of interpreters or multilingual staff can hinder communication, uh, insufficient training, and culturally humidity and trauma reinforced informed care leaves providers feeling unprepared. Limited funding for culturally tailored programs or community based partnerships. Emotional and cognitive barriers. Providers may experience unnecessarily frustration or helplessness when navigating unfamiliar cultural norms. Fear of getting it wrong can lead to evidence of superficial engagement. Some clinicians report opposition or resilience or resistance to culturally adaptive practices, especially when they feel it conflicts with biomedical norms. Communication challenges. Language barriers remain one of the most cited obstacles. Cultural expressions, distress, e.g., uh, somatic symptoms like headaches instead of sadness, may be misinterpreted. Nonverbal cues, storytelling traditions, indi- or indirect communication styles can be misunderstood. Symptomatic bias, systematic bias, and inadequate institutional racism. Okay. exophobia, and enablism can be embedded into care protocols. Standardized assessment often fail to capture culturally nonsensed experiences. Policy gaps, such as lack of or reimbursement for culturally tailored services, dis- discourage innovations. Lack of community engagement. Okay, guys, so that is D for you. I will see everybody tomorrow for shows. Until then, Gator Wellness. Take care, folks.